Thank you, Arun, and good afternoon, everybody. Uh, we have been talking about symptom control and communication ethics. Now we are coming to almost end of our FCPM program. This is on end of life care. Uh, all of us have managed many patients end of life, but um, when you look back and reflect on, do you think you have managed the end of life in a good manner, or were you able to provide a dignified death for those patients who were under your care? This is something which we would um, which is going to be beneficial for us, because at the end, uh, uh, many of us and all of us and some of our many of our all of our relatives are also going to die. So we need to understand whether can we do something else for these dying patients rather than doing the same thing which we were practicing since our uh, MBBS days. Uh, I just want to tell a story for 2 minutes. So this was a patient, a patient with advanced malignancy who was brought to casualty while I was working in a tertiary care hospital, and in fact the biggest hospital in Kerala. And this patient was gasping. So immediately the palliative care physician was called in. I just went and saw the patient. So as per protocol, the patient need to go into ICU. But I just had a talk with the relative. The son was not there, and told him that the patient is gasping. He will die at any moment. And I told him that it is not necessary to shift him to ICU. He's comfortable now. He doesn't have any difficulties, and if there are any difficulties, we will manage. So after that, he was allowed a side room, and the son and daughter who were not there came in after some time, and I instructed the security to get them in, and so they were also with the patient. And within I think 45 minutes to 1 hour, the patient passed away, and the son and daughter came to me and thanked me a lot. At that time, I thought I didn't do anything, but still they are thanking me. Why? So uh, I think sir will be talking about this more, and it's over to you, sir.
Thank you, Sunil. Hello, everybody. Good evening. Can I start with yet another story? Now that Sunil has told the story of how a family was grateful for care for the last hour or so, I am going to show you her picture also in a minute. This was about a patient whom we treated here in Trivandrum. This woman had cancer. She was living in an old age home run by a church. She did not have she did have a family. She had one daughter. Her husband was no more. Her own daughter. She was a very poor woman, was married to a man who was a drinker. And therefore the daughter was finding it very difficult to even feed her children. And this woman was put in this destitute home. She was very dependent on us. Our weekly visits, would always hug whoever she could get, because she was so craving for human touch. She had pain, we put her on morphine. And as her condition deteriorated, she was complaining more and more about her daughter, how ungrateful her daughter was, how the daughter was drawing the pension that was due to this woman. And this went on, always grumbling. And she was deteriorating very fast. And we decided somehow we must get the daughter to meet the woman. You have all learned a lot of science, doctors, lot of hard science. You have learned about every system in the body, about the chemistry, about the pharmacology. None of that really prepares us to solve the greatest problem that this woman and her daughter had. The daughter did not have a phone, and we got in touch with her through a neighbor. It was difficult, but we got in touch. We said, your mom may not last long. You have to come over. The daughter cried and said, I cannot. I have no money. We said, we'll send you money. She said, that's not enough. My children will starve. So what we did was to send money, not only for her bus fare, but also for her children's food, so that she could get a neighbor to feed her children. The daughter came, emaciated woman, maybe around 40 years old, skin and bones, a picture of sorrow. The mother so far was always angry with the daughter. She's not coming to see me. She's taking my pension, etc., etc. But one of the most satisfying memories for me in my life was the sight of the two of them hugging each other, crying together. Last 3 or 4 days, the daughter was always with her mother. And as we went, I could see the daughter. This hand on the forehead of the mother was a constant feature. The woman died, but I think she died a good death. That good death was possible because we could relieve the woman's pain with morphine. We could relieve her other symptoms. But she died a good death also because our team did not consider its duty when the pain was relieved, got the daughter and the mother together. Very few people in our country are lucky enough for that. The vast majority of people do not get symptom control, do not get pain relief. An international organization called the Economist Intelligence Unit created a quality of death index. And it doesn't show India in a very good light. This is the woman dying with a few drops of water down her throat. Many of you in this group have had faced death in the family, your relatives dying. And because you, majority of you, come from middle class or well-off families, the second picture may be better depicting of what death in India looks like for the majority of Indians with any money in the pocket. I don't know which one of you is going to treat me when my time comes. But if I am forced to choose between the two, I would end choose this old woman's death. Doctors, I am an anesthetist. I did critical care for a lot of time. I managed a lot of people in intensive care units. I know intensive care has great value in saving people who are salvageable at a critical time of their lives. But when we force a person who has no chance of regaining a reasonable quality of life, when you put a person with COVID-19 in the age of 84 on a ventilator, when you put a person with chronic obstructive pulmonary disease on a ventilator in old age, you are forgetting the basic purpose of medicine. If you treat me, please don't put me through that. If I have a salvageable issue, maybe a fracture ribs, I need ventilation for 3 or 4 days, I can come out. Do please put me on a ventilator. But if I am dying of dementia, cancer, or Parkinsonism, please don't do this to me. It violates all principles of decency and justice. India is placed among the worst 15. It comes here. Shame. Sri Lanka is above us. Kenya is above us. Zambia, the very poor country, is above us. We are classed as poor, having poor quality of end-of-life care, mainly because we don't relieve symptoms and because we give inappropriate end-of-life care. This article, I have given the link there. I would recommend that all of you read this article. It was written by a young woman by name Sindhu in the newspaper Hindu. Would somebody like to read it out for me? Who is volunteering? Let everybody hear a better voice than mine for a change. I don't know if nobody is volunteering. Please nominate somebody. Just read it out.
I'll read it out, sir.
Thank you, Ashish. No, Abir. Yes. Please do.
So my 85-year-old father, my best friend, was enduring raw intrusive dental procedures against his own wish. All skin and bones, he looked defenseless and at the mercy of doctors, his arms tied up, vulnerable and agonized.
Many of you would remember this picture of people in old elderly people in intensive care unit, arms and legs tied up. For heaven's sake, please don't do this to me. This is the ultimate cruelty, to tie people up. We do not even do this in prisons, even to people on solitary confinement. This is the worst kind of death. Internationally, a critical care physicians, the group, physical restraint is a rare thing that you have to do. You may use chemical restraint with medicines, but this is inhumane. It violates every fundamental principle of medical ethics: autonomy, the person's right over himself, beneficence, doing good, non-maleficence, not doing harm. We are causing the ultimate harm to human beings when we do that. And it violates the principle of justice, of fair play. When we incarcerate people at the end of life. I'm sure what I'm saying is very painful for a few of you. I don't want to ask who it is, but some people have gone through it in your own life when a parent or a grandparent died. We forget then, when we do that, the duty of care of the healthcare provider. I think I talked about this when we discussed ethics. The duty of the healthcare provider, according to Indian Council of Medical Research, which is the statutory body of Government of India, is to mitigate suffering. You and I have a duty to mitigate suffering, to cure sometimes, relieve often, and to comfort always. There is no exception to this rule. You can't make an exception for dying people. And when my time comes, aware, if you are treating me, please remember that your first and foremost duty, if I am dying anyway, is to make me as comfortable as possible, not only physically, but also emotionally. Treat my pain, treat my breathlessness, treat my nausea and vomiting. You may not be able to do a perfect job, that's okay. Do your best. And remember that I am not only a body, I am also my mind. If I am afraid, you have to ask me, why? What can I do for you? I may feel that I am in a strange place where I have no friends. Aware, please hold my hand and tell me that I am going to look after you. The fact that someone tells me I care for you can be very precious at that period of time. This morning, I did a home visit to an 86-year-old woman in severe ischemic pain, crying out aloud and claiming that her own children are torturing her. They are giving her, in their opinion, what is the worst, best treatment. To her, that is the worst. My physical and emotional well-being, aware, who I hope will be your consideration primarily, much more than my renal function or my cardiac output or my oxygen saturation. I cannot possibly die with a normal oxygen saturation if you are not artificially doing cruelty to me. That is natural. Sodium will fall. Hyponatremia is a part of the dying process. Hypoxemia will happen. Hypotension will happen. Eventually, heart will stop. At that time, Abir, I hope you and your friends will not jump on my chest and do the ultimate dignity. I know that CPR has a role when the person can be brought back to reasonable quality of life, not to everybody who is dying. It is insulting to the person and to the body. But making me emotionally comfortable has to start early, as early as you will have to be quick. But if you are treating me for the next 1 year, early on, find out, do I know what's happening to me? Do I want to know? If I want to know, please tell me. Do I know how long I have? Oh, no one knows. You can easily say that I ask Abir, how long do I have? Abir can, in all honesty, say, we don't know. But a more kinder answer is, we don't know. It is unpredictable. But why did you ask that? Is there something that you want to do? Is there any unfinished business? You want to talk about it? Give me the chance. I would say, can you discharge me? I want to make sure that my will is signed. That's important for me. Have I expressed views about my care? Ask me, where do I want to be? It's my choice. I don't know how many people in this group are able to think about your own death. A few of you will be. A few of you will not be. That's natural. But those who are able to think about it, please tell me by chat, where would you like to be? Home, hospital, ICU? Arun, Sunil, will you please monitor the chat box and tell me?
Dr. Asha says home.
Can't hear you, Sunil.
Dr. Asha says home. Shweta, home. Dr. Dimla says home.
Sunil,
Yes,
they all want to be home, but Sunil, I want to be in your care at the palliative care center.
Dr. Ashish also says home surrounded by loved ones.
That is something that I must have. Sunil, there is a reason why I want to be admitted by you in the palliative care center. I know that this death at home is a romantic idea, very nice. But if I am breathless at 2 o'clock in the morning, who will look after me? If I have an breakthrough pain and I am in agony, who will care for me? Home, everybody who said home, yes, if we can get the right care across to people's home. I know of 2 organizations in Kerala. We don't do it, Sunil, but at least 2 organizations in Kerala provide 24-hour care. One of them even during the COVID days. They take emergency calls even at night. If that were available, I would have chosen to be home. But when you admit me in your palliative care center or in a hospital room, there may be no palliative care where I am. If I am in a hospital room, I hope the family will be allowed to be with me. I may have important things to do. I may want to tell my wife once more a final message. I may want to say, I'm sorry, I wish I had given you a better life. That's important for me, for my peace of mind, for her peace of mind. I may want to hold on to a child's, my son's hands. Those are very precious things for me. That has to be made possible. And incarcerating people in intensive care units is indecent, unfair, and if there was any justice in the world, an act of criminal torture.
So there is a comment
Yes.
by Dr. Avanish. He says in the Middle East, there is no concept of DNR. Common point is in favor of CPR, even of unsalvageable people, is that who are we to decide the destiny? It is only he who can decide. We have to do all the effort. What are your views about this? And he also says he is curious to know about where these countries stand in the survey in terms of end of life care.
Uh, sorry, what was the name of the person who asked the question? Avanish.
Avanish.
Avanish, the Middle East country. I do not exactly remember the count, and that document is not very easily readable. So I don't know, but they stand very, very bad. The Middle East is very bad as far as end of life is concerned. Saudi Arabia has 2 or 3 palliative care centers. In the whole of UAE, there is one. Qatar has one. Most other Middle East countries have none. They are horrendous. I myself have worked in a Gulf country so many years back. What is happening in a Gulf country or in our country is that we have become very, very technical. We provide high-tech care. This was my last slide. Because Avanish asked this question, I bring it up first. What is the doctor's perception of duty of care? When Western medicine was copied mindlessly in India, we talk about only Middle East. Same thing in India, Avanish. It is a 22% of people, intensive care units, have a policy regarding DNR. Otherwise, people have to die on ventilators unless the family comes and says, we have no money. So let us not talk only about the Middle East. the doctor's perception of duty of care, they think it is due to prolong life. Many of you may have this idea within your minds. You do not have a duty to prolong the heartbeat at any cost. Your primary duty of care is to mitigate suffering. You cannot prevent death at all costs. I know that will be complicated by legal facts. Family may will keep saying, I can't let her go. Save my mom. That's a selfish kind of love. What that daughter or son needs help is to accept, to arrive at this decision. I don't want her to suffer. It is tough time. Let her go. I live on those memories. So it is not only the doctor's duty of perception of care. In the Middle East, over a quarter of a century, the Western medicine has established a system that everybody has to be subjected to this jumping on the chest and the brutal cruelty. And the legal situation is confusing in India also. I know that all these are also problems. But doctors, let us start here. When I know Avnish cannot do this, practice this in Middle East, but Avnish can at least talk to friends about it, initiate a conversation, have in one of the doctors' meetings an invited talk by somebody from USA. People from USA are respected secretly in most of our countries. Have an intensivist from USA talk about withdrawal of life support. That will attract attention. No, I am not saying that I have all the answers, Avnish, but what is happening there in Middle East and here is a cruel practice of medicine. So what we need to do, depending on my express wishes, initiate a conversation with my family also, decide where you are going to treat me, how much of artificial life support I want. It is very rare that I will say, I want to die on a ventilator. And very often we come across this funny business of a lefty being checked even on the last day. Blood checks continued. And the patient whom I saw this morning was still getting atorvastatin. She has limited life on this place. Unnecessary medicines and routine blood checks should be stopped. I wouldn't. Hey, Dr. Avnish, if you are treating me, please don't put an nasogastric tube if you know I am dying. You are worried about my nutrition. What the hell? You can only get food into my stomach. You cannot push it up into my cells. In the dying process, need for food drops, need for water drops. If I need water, give it subcutaneously. Parthasarathi Shom was the former financial advisor to PM. And he wrote a letter in the Business Standard about his mother's dying. Hey, who was reading it out for me? The volunteer, please come forward once more. What is... sorry.
Abir, sir.
Yes,
Abir,
please. Yes, yes, sir.
I
Abir,
cannot
please.
see your...
I am sorry. I am sorry. I forgot to share the screen again. Stupid of me. Abir, where do you work?
Sir, work on a cruise ship actually.
Excellent internet facility on the cruise ship.
Even on Parthasarathi, former financial advisor to PM, even on the day of passing, a specialist recommended a liver function procedure. When asked if it would end the coma, the answer was in the negative. Compassionate and palliative care, the business standard.
Continue.
That's all, no, sir.
So next, I have shown the next slide. Please read.
Okay. Female and male nurses hurried about pushing and shoving the inert body, robbing any peace, contemplation, or prayer. Where was palliative care?
So we need to start asking at some point of time, how is he? Rather than what is the BP. For a dying person, the BP doesn't matter. The position change and skin care have to be aimed at achieving a balance between certainly pressure sores need to be prevented, but every 2 hourly change of position may not be necessary if you put in an airbed and ensure comfort of the patient. And even if I seem to be unconscious, dear friends, please talk to me. You don't know. You don't know. I may be unable to react. I may be able to hear something. Till I am dead, remember, I am still alive. Deal with me like a human being, even if I appear to be unconscious. Before you turn me rudely, please tell me, we are going to turn you. Please tell me, your son is here to see you, even if I seem to be unconscious. And help my family. Give them information. Help them to cope. Particularly remember children. Children have numerous questions in them. And my grandchild, as he or she hears that I am dead, the thoughts go through, will my dad also die? Who will look after me if my dad and mom die? These are the ways that children often think. You need to give explanations to children. And if I believe in religious rites and my family believes in it, that must be facilitated. And family's presence must be encouraged. And my one problem I expect is that my family, my wife, during these days of intense stress, may have her diabetes go out of control. Health situation of the family and emotional needs, somebody should be looking after. Maybe at some point, sorry to be forcing you to choose these things, we think about ourselves. Please think about ourselves, our death, our loved ones. Do we want to do to patients what we do not want for ourselves? We know that futile and inappropriate artificial life support measures usually cause physical, psychological, and social suffering to patients and families. They should have palliative care. And when I talk about withdrawing artificial life support, stopping the ventilator, some people may have this question, am I talking about euthanasia? By no means. Allowing natural death is not euthanasia. Euthanasia is the intentional act of killing a terminally ill patient. Deliberately, the ICMR uses the word killing. It may sound brutal, but that's the truth. In euthanasia, a person is killed. What we are talking about is not killing anybody. We don't do anything active to end life. We only allow natural process of death. And there's no such thing called passive euthanasia in scientific terms. ICMR repeats this. The term passive euthanasia is an obsolete terminology. Euthanasia cannot be passive. Euthanasia means killing somebody. Intention's good, but it is still killing, and that's illegal in our country. If we talk about withdrawing a ventilator and allowing somebody to die, that is not euthanasia. So if I am already on a life support, it happens sometimes. I get ill at night and my family rushes me to the emergency room. You don't know that I am having advanced cancer or dementia or Parkinson's. So you put me on a ventilator. But you can always withdraw that later at the appropriate time. You have to see, have I written an advance directive? Hey, ladies and gentlemen, I have written my advance directive. I have shared it with my family. My family understands this. But of course, 3 physicians have to perform an evaluation to make sure that I do have an unsalvageable condition. And it is not only a procedure of just disconnecting the ventilator. 2 important things. Listen to my family, answer their questions. Don't consider them your enemies. If they have opinion is different, we need to be on the same side. Acknowledge their suffering. They may be angry with several things. Acknowledge their anger. Please remember that they love me. And if they fight with you, they do it because they love me. Say that, I see you are upset. I see that you love your dad very much. You want to do the best for your dad. We also want to do the best for your dad. Sit down. Let us talk about it. And to them, suggest only realistic treatment options. I'll stop the share for a minute because I want to talk to you. A few weeks back, a friend of mine died. He is a doctor, the husband of among a doctor couple, running his own hospital. He was on the ventilator for 56 days. For 35 of those days, he was on an extracorporeal membrane oxygenator. The family was destroyed. This man who had built up a hospital, successful hospital, eventually left the family destroyed. And there was this collection being taken among friends to pay some of the debt to the hospital. I wouldn't want to go with the feeling that I have destroyed my family. I hope you will give the family only realistic treatment options. If I am dying of COVID-19, the membrane oxygenator has very little chance of success at my age or even artificial ventilator. Well, while the family may be confused, allow time, continue existing measures, and they may say, okay, BiPAP is okay, but don't intubate his trachea. Maybe you will have to accept that. Don't bring up the cost at that time. They may think, okay, if we had more money, we could have saved it. And never ever say nothing more is to be done. That's a very painful thing for the family to hear, and it's not true. There's no situation where nothing more can be done. So long as I am alive, or even when I am dead, there are things that you have to do. When I am alive, to make me comfortable. When you are withdrawing the ventilator, you are not going away. You are going to give me palliative care instead. Sunil and I worked for a few years in an institution where from the critical care unit, patients would be taken to the high dependency unit, otherwise commonly called step-down ICU. And we created a palliative care unit next to that. So from the high dependency unit, maybe with BiPAP, they would be transferred to the palliative care unit. They were not abandoned. The family would know that the person is being cared for. The person doesn't feel abandoned. The usual practice of putting the person on an ambu bag and on a ambulance and sending them home is barbarous. We need to continue palliative care. We created a counseling room where access was there. So from this point of time, the family was continuously told what's happening, and they were given time to get used to the idea of the person dying. And to all of you, most of you are young. Sorry to say this, but there is no age limit for this. If you are an adult, you should think about these things and prepare your own advance directives. Remember, you have the legal duty to respect my wishes. I have written it. I have talked about it to my family. They know what is to be done. This is legally binding according to the Supreme Court judgment, provided some procedures are to be followed, which are complicated, unfortunately. India does not have a law pertaining to end-of-life care. Therefore, the Supreme Court judgment will still be valid. But remember, the doctor's primary duty of care cannot be forgotten. Invoke the law only when there is an issue, only when there's a conflict of opinion between the patient, doctors, between the patient and the family, between the doctor and the family, between the hospital and the family, only when the legal issues to be brought up. Because when I am your patient, ladies and gentlemen, remember your first primary duty of care to mitigate my suffering. You do not have a duty to keep my heart going even when it is futile. Of course, I know that there are problems, as I said already. The family may be protective to me, and my family may cry and say, no, don't allow him to die. You need to hold their hand for a few minutes, sit there and share their grief. I know societal factors are a big problem. In Trivandrum, if anybody dies in the middle class or well-off family, as they are dying, the question is, why are you keeping him here? Why are you not taking him to KIMS? KIMS is the biggest hospital in Trivandrum. That's the society's perception today. Just as Avinash said, in the Middle East, the perception of duty of care by the society today is for CPR. They didn't have this idea by themselves. We, the medical system, planted this idea and they believe it is wrong. But of course, whatever it is, you cannot go against the law of the land. The legal reality has to be borne in mind. But you may not be able to do what you think is right. But at least in your mind, know what is right. Try to do what is right. And if you cannot, because of legal factors or societal factors, family's attitude, at least you will have the satisfaction. I have done my best. Thank you, ladies and gentlemen. I see that I have 15 minutes more for a discussion before the case presentation. Thank you, Abhinesh. Thank you, everybody, for listening in. The Sunil, as you have written in the chat box, the advance directive to be legally valid has to be countersigned by the first-class magistrate because of the Supreme Court judgment. But let me add a word to that. I haven't got it done. Nobody ever gets it done. In the whole country, not more than a handful of people have done it. It is not easy to go to the judicial first-class magistrate and get it done. Who has the time? So please remember what I said earlier. Sorry, 1 second. The legal issues come up only if there is a conflict. Sunil, I have written my advance directive. I have not got it signed by a judicial first-class magistrate. But when you treat me, don't throw that document into the trash bin because it is not signed by the magistrate. It becomes an issue only if there is a legal conflict. If you are in agreement that you will be doing me a disservice by putting me on a ventilator, and if my family is in complete agreement, all that you need to do is to write on my file. There is no point in artificial resuscitation. That would be against the patient's wishes and against the family's wishes. All measures will continue for comfort. There will be no problem. You sign it, have it witnessed. There will be, I'm sure, thank you everybody who said you liked the discussion. But I'm sure there must be conflicts in your mind. And maybe some people even may want to share experiences. If most welcome, but those who share experiences, limit yourself to a minute or two because we have to listen to everybody. Yeah, Radha Ganeshan asks, any format form for comfort care? Let's say you cannot have a format only for comfort care for the dying because the process had to start early, Radha. You cannot only give end-of-life care properly. The whole thing has to start early. But yes, indeed, there are protocols. One of the most famous protocols was created in the UK called Liverpool Care Pathway. Dr. Radha Ganeshan, I am glad you asked the question. That gives me the opportunity to explain it. So Liverpool Care Pathway was created some 20 years back. That is, if the person's life is considered unsalvageable, incurable illness, you put the person on a pathway where you would have pain management, comfort measures, etc. The problem in having protocols is that it becomes inhuman. Okay, Rajagopal is on pathway. People start dismissing me. Pathway, hey, no, don't do that. Don't no antibiotics for him. He's on the pathway. Whether or not the family and I am in agreement with every point. And so the pathway went into a lot of legal hassle and was withdrawn in the UK. That doesn't mean that all protocols are bad, but protocols have to be practiced with humanity and with compassion.
Sir, there is an interesting comment on the chat.
Avanish is using the term counter legality should be allowed. If a patient wishes DNR, hospital doesn't follow the wishes, they should be held legally liable. I agree, Avanish. For this, what is necessary is a law. The law should be binding on doctors. In fact, in the year 2016, only 5 years back, India did propose end-of-life care law. It was put upon the Ministry of Health website and public comments were sought. I understand that there were more than 1,500 comments reaching the government. We also sent our documents. It was a rubbish document, honestly. It needed a lot of work, but they dropped it. Those were the days when there was so much of political turmoil. Very little legislation was happening. It was never resurrected. So, Avanish, we need to have a law that is humane and friendly to the dying people. And this signing by the magistrate is something that the Supreme Court did it. Maybe the Supreme Court lawyer wouldn't know how much a problem I would have in accessing a magistrate's court. How much time does he have left? And how would I get it signed by him? Mahesh Mota asks how to counsel the patient's relative to go home at end of lifetime of loved one. How to counsel the patient's relative to go home? I don't want to. I would sit down with the patient and the family. I would ask the family, like, this is the situation. What we need to do is to make the person as comfortable as possible. I personally would not recommend an intensive care unit. I think we should look after him where you can be present. That can happen in our hospital room. That can happen in your own home. The person may say he always wanted to, he used to say he wanted to be home. He was asking me to take me home during the last 3 weeks. And I would say, please consider taking him home. I'll give you medicines and I'll tell you what to give for each eventuality. This is very important. We very often send him home with a discharge summary. Here, take it, go. If he gets breathless, this is what you should do. If he develops convulsions, this is what you can do. Usual problems, not every problem. Prepare them to deal with the problem in their home and then say, but have the number for an ambulance ready with you. If you find that you are unable to cope, put him in an ambulance and come back to us. We will look after him. The majority of families, if this conversation has happened, will say, I will take him home. Some will be afraid. And the fear is very well founded. At 2 o'clock in the morning, when the person is breathless, they panic. And we are unable to give them enough support. In Pallium India, Sunil ensures that there is a 24-hour helpline. Any family member is, the card given to them gives the phone number. Anybody is welcome to call us anytime during 24 hours. At least telephonic support can be given. This is essential.
So just want to share an experience that happened here 2 days back. So we had a young patient who has an advanced malignancy. He was on fentanyl infusion, and actually the patient and the family wanted to go home, and actually he was nearing end of life. He was comfortable, so the family was not in favor of infusion. So we put on a fentanyl patch and we started on morphine, and along with that we gave injection fentanyl loaded syringes, and then the necessary instructions were given and our phone number and to call anytime, 24 hours, and patient went home. He was comfortable that night, and the next day our home care team, our special home care team actually went to see the patient, and he died peacefully in front of them.
Thank you for making those things happen, Sunil and team. I'm very proud of a team which makes that kind of thing happen. It requires commitment, it requires experience. Unfortunately, the man died during daytime. If he died at 3 o'clock in the morning, we would not have given enough support to them. That's also a reality. But we can only try to do our best. In palliative care or any healthcare, we have to accept our limitations. We may not be able to do everything that's good for the patient. We have to remember that we are human beings. We can only try our best and accept our limitations also. Sunil brought up an interesting statement. Sunil sent a patient home with a loaded syringe of a controlled substance, injection fentanyl, in a syringe with the family. Is that permissible? I'm not asking Sunil, I'm asking the audience. Did Sunil something that's legally questionable?
Yeah, Dr. Abir says it is not permissible.
It is?
It is not permissible.
Abir, there is no law which says either that it can be done or that it cannot be done. The law doesn't prevent you from sending an injectable opioid with a patient. The same rules legally apply for injectable and oral. That's one thing. Everything legal, I mean, that would be not against the law. That's what I'm saying. But we also have to be reasonable. Will you send 4 ampules with the family? That's risky. Injectable opioids are dangerous. So how did Sunil send this fentanyl? Did he send 2 ampules with the family, Sunil?
No, sir. I only gave loaded syringe.
So, ladies and gentlemen, if there is no law covering a subject, courts go by a few things. If there is law, of course, that. 2, if there is no law, based on the judgment by the highest court. If there is no court order, court judgment also, they may go by international law or decisions of statutory bodies like ICMR or Medical Council of India. None of this is covers in this situation. And in the absence of anything else, courts go by professional bodies' guidelines. So there is no law, no court judgment regarding this, no statutory bodies recommendations, but Indian Association of Palliative Care has a position statement saying that injection of pain relieving medicines by the family to the patient is permissible. If you think in another way, you are allowing the family to give insulin, which is a much more lethal medicine. And Sunil is sending an ampule with a syringe, with a loaded syringe with a marks, which cannot be sold on the market. And he is sending in with enough instructions. So this you should know that guidelines created by Indian Association of Palliative Care permit it, and in the absence of any law preventing it, that should be good enough. We have been practicing it for a quarter of a century. We will continue to do it. What is Archana asking? Should we write on paper? What does it mean, Radha? Radha, what do you mean by should we write on paper?
That's why Dr. Archana.
Archana? Anyway, what is necessary? Archana, your question is still not clear. Instructions.
No, I think sending it to home
Yeah. Yeah, we are giving a drug chart. We are giving instructions. Of course, we must give instructions. We give instructions to the family. Radha, but narcotics and sedatives, how can we? The Indian Association of Palliative Care specifically talks about opioids. That it is essential. I take you back to the bar chart that I showed you. First, our duty of care. If it is legally invalid, we will not do it. If there is a law against it, we don't want to do anything that is illegal. But if there is no legal objection, I would do it. I would primarily look at my duty of care. Is the family accepting? Yes. Is there anything against it? Suppose it's against a religious belief, we wouldn't be able to do it. In the Gulf countries, very often the local belief system is that any sedative should be avoided to the dying person. That may be a local belief and that has to be respected and legal. If there's a law against it, I wouldn't do it. There's no law against it. There is no societal factor against it. In these patients of Sunil, the family is willing. He has written it down. We are not doing anything surreptitiously. And we are not sending an ampule which can be sold in the market, sending a loaded syringe. And we are doing something that is abiding by the Indian Association of Palliative Care guideline.
Dr. Bismi is asking, should we give a written prescription?
Always we must. Any medicine that we give, we have to take responsibility for that. Nothing surreptitious. You do anything without clear documentation, that is troublesome.
Emergency department. I had one of the patient bystander. So he every time comes with a prescription telling that his mother is sick, and she with a prescription from Calicut Medical College. I don't remember whether it is palliative care department or it written injection 14 injection Finagan. So he comes almost every other day to, and we'll ask because the hospital won't give you on that prescription. So he'll come to the emergency department, and if somebody is there, he'll ask them to write it down for us because my mother is very sick, nothing else work for her. So we should write this medication for him, and then he buy this and goes away. So when this continued for almost a week or two, every other day he used to come this and buy. Then we got a little suspicious, and then we angered his mother has been already passed off. So, but he still comes off with that prescription which was long back. Get a prescription from us, and think he was abusing, and that was one thing.
Abir, thank you. This is the other side of the story. When we talked about opioid availability, we talked about the principle of balance. Abir, I have a duty to make medicine available to the patient for pain relief. I also have a duty to prevent abuse of the medicine. This is not an infrequent story, not very common, but at least 4 or 5 times during the last quarter of a century, I've come across this problem of somebody getting dependent on Fortwin. Fortwin is the commonest, possibly because that is more easily available. You can't get morphine. Now it is tramadol. More people get hooked on to tramadol. I will realize that majority of them are having physical dependence and not addiction, but some may be addicted. I would not look at them as if they are criminals. I would look at them as people deserving of my compassion, as patients with a medical problem of either physical dependence or addiction. I will be compassionate to them. I will try to treat them or to direct them to a place where they can get treatment. But I will not give that injection Fortwin. Before I will not write that prescription, and we will do exactly what you did. We will make inquiries. In one instance, we even had to, because we could not get through to the family, we got to the local post office, got the postman and send a message to him, to the family, to call back. We want to talk to the patient, and that ended the problem. Thank you for that sharing. Sunil, I am already late by more than 5 minutes for my meeting. May I leave?
Okay, sir.
Ladies and gentlemen,
Yeah.
I think you are coming to the close of the course. I hope we will be in touch. We'll have many more opportunities to meet up again. I wish you all the best.
This
And
is
thank
not
you
the
very
last session, sir.
No, no,
Last
okay.
session is the next one.
Yeah, but I am not going to be there, right?
No, you are going to be there, I think.
I see.
So period
Okay.
availability.
Okay. I thought it was done. Okay, see you next time then. Bye-bye.
Okay.
Yes, Avinish, we'll
Thank
meet.
you, sir.
Bye-bye.
I think we can move on to the patient story, which will be presented by Dr. Gina Elisa Thomas. Dr. Gina? I don't. Uh, Gina, please unmute yourself.
Gina ma'am?
Good evening, everybody. I am Dr. Jeena and I'm working in Kachua, Kachua Christian Hospital, which is a unit of EHA. Kachua is near the holy city, Banaras. And today I'm going to present to you a case which has involved most of our hospital staff and has touched most of our lives here in our hospital. Next slide. So this is about a 74-year-old female who had presented with left leg cellulitis and severe anemia, and then later on developed necrotizing fasciitis and CBA during a hospital stay. She presented to our OPD on 10th of July 2020 with complaints of burning sensation and swelling over left leg and giddiness since 3 days prior to presentation. She was apparently well till 3 days prior to presentation. History of illness. She was admitted in our hospital initially for the management of left leg cellulitis, and the debridement was done. She was apparently well till 3 days prior to presentation. She was admitted in July 2020 and was discharged on request after the debridement of the wound, and she was advised to come for dressing of the wound. A week later, when she was brought back to the OPD, the wound was even more worse. She was then admitted in a separate section in our ward just for palliative supportive care. And later, during the course of hospital stay, she developed stroke. After she developed stroke, she was completely bedridden. She hardly spoke to express anything, and supportive palliative care was given. She was catheterized, so catheter care was also done. Examination, when she had presented to our OPD in July 2020, she was conscious, oriented, afebrile, thin built. Her BP was 70/40, saturation was 99%, GRBS 58, respiratory rate 18 per minute, S1, S2 heart. Examination of the wound on the left leg was erythematous with swelling extending from the left ankle to the left knee. The skin surrounding the wound was dry. There was tenderness over the left leg. It was warm and it also had blisters. Few were filled with blood and few with fluid. She was discharged after the debridement was done on request, and later when she returned, the wound had irregular margins with slough, margins everted, extending above the knee. The skin surrounding the wound was dry, and she had also developed pressure sores on bilateral buttock, which were grade 2. Next slide. treatment and significant investigation. In July 2020, we are working in a primary care setup, so we have limited investigations. Uh, Her HB was 6 gram, GRBS 56, her TLC was 4,000, with predominantly polymorphs 90% on 10th of July, which later increased to 12,600 with predominantly 95% polymorphs. Her BT, CT, creatinine, platelet, Vidal, sodium, and potassium was normal. We had requested for blood transfusion to her son, but her son could only arrange for 1 unit of PRBC. So her repeat HB after blood transfusion was 7.2. She was started on IV fluids, but later developed generalized edema. So IV fluids was also stopped. She was later on Ryle's tube, and protein-rich diet was given through the Ryle's tube. She pulled the Ryle's tube and was resisting the reinsertion of Ryle's tube. So sips of semi-solid diet was started. She had developed contractures. So regular exercises were done by our community health team. She later developed pressure sores. Her pressure sore dressing was done regularly. Spiritual and mental health. The hospital staff would visit her every day and spend time with her for prayer and encourage her to eat and try to feed her. Her son was with her during the entire course of hospital stay, and all unnecessary interventions were stopped and all IV drug medications were made orally as tolerated. Next slide. Okay, psychosocial aspects. So she was a widow, survived by her only son, 42-year-old. Her son was an alcoholic and was an IV drug abuser. She managed to educate her son, who completed MA, but because of his addictions, he was backsliding in life, and that worried her. She was surviving on meager pension amount that she used to get, and with the tuition classes that she would take every evening. Financial constraints as she wasn't able to earn for the family. And post debridement, dressing was required, and her son was not able to do it. She had her brothers who stayed in the same town near Kachua, but they never helped her. All she had was a piece of land and a house, both of which were in demand, and all her other family members wanted to have it. She hardly had friends who would visit her, so she would feel lonely most of the times. She was an active teacher till she became ill, and slowly her medical condition limited all her daily activities. Medications. 1 unit of PRBC was transfused because her son could only arrange for 1. And we do not have access to higher grade antibiotics. So with the limited antibiotics that we had, we managed this patient. We started with injection augmentin 1.2 gram IV BD, tab iron OD, injection diclofenac 75 mg IM TID, and only when the pain is really bad is when we used to give her injection tramadol 50 mg in 100 ml NS slow IV PRN, syrup multivitamin 5 ml OD, tablet lactobacillus BD was added on later because she used to have loose stools, and debridement was done on the day of admission under ketamine, and later we used to do saline dressing OD. Later, when she was readmitted for supportive palliative care, we made all IV medications oral. For pain management, tablet diclofenac 50 mg TID was given, and because her wound was foul smelling, we used tablet flagyl, crushed and powdered it on the wounds. Her main concern, the most important, was about her son. She wanted her son to be transformed as he was addicted to alcohol and IV drug abuse. She was worried for her son as she had nobody after her who would take care of her son. Her son had no job and it was difficult to meet the ends for the son. She had very few friends who would visit her and get food for her. We couldn't get any tertiary consult or radio imaging done for her. Our hospital management team tried helping by giving him a small job as a manual laborer. Part of the salary which was given to the son was used for the treatment, and the rest of it was given to him in small installments so that he doesn't use it to buy alcohol or drugs. He was counseled so that he could come out of his addiction slowly. She wasn't talking, but she would make noises to express her likings and dislikings. We were also trying to support her in that process. Son, and she died peacefully on 1st of November 2020. Summary: a 75-year-old female who presented with left leg cellulitis with severe anemia, later developed into necrotizing fasciitis and stroke and pressure sores, admitted in a small primary health care center for her wound care, physical pain. She died peacefully after 3 months with her son by her side, who was on the path of transformation. Discussion points. Number one, what else could we have done for our treatment? We have a group of junior doctors here with one medicine consultant and a surgeon and a community team here with limited super specialty people here. We tried to manage the best we could for this patient. Number two, could we offer palliative or supportive care with limited resources and minimum expenses? Here, the patient and the relatives were not affording, they were not even earning. So it was difficult for us also to manage the expenses for the care and management of this patient. Number three, with limited access to CT scan and high grade antibiotics, did we do justice to the patient who was suffering to the management? This patient could assess pain in such patients who are bedridden and who cannot vocalize their concerns. The only way we could get was only when the patient would make noises. That's when you would understand that the patient is crying in pain. And number five, in such situations like these, where the patient and the caregiver are not in a condition to decide anything for the patient, the important pillar of medical ethics, autonomy, is at stake. So, how do we tackle it?
Thank you, Dr. Jaina. So I am inviting comments from any of you. Dr. Bismi says very well managed. Why was she so anemic?
Yeah, so one reason that we could think of is she was quite thin built. So I assume that her nutrition was very poor. She couldn't manage. Also, we couldn't find out other reasons for anemia. There was no history of blood in stools, and to rule out other gynec concerns like PSPV and all we did, but there was nothing else that we could find for anemia. Malignancy was one thing that we thought of. Um,
Okay. So please come up with your comment. Please unmute yourself and speak. So, what do you think about the treatment that they have offered to the patient and her son? Anybody? We have 37, including me, there are 37 people attending this. So, any of you, please. Dr. Bismi, are you talking?
The treatment seems to be adequate. I am just confused why she's having anemia. I mean,
Mm.
6 really low
Yeah.
for a nutritional
Yeah.
anemia.
Yeah.
So was peripheral smear done? That wouldn't
Mm.
be very expensive. So that is one question I have.
Okay. 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 Thank you.
Yeah, peripheral smear showed microcytic hypoproteic anemia.
That is not very helpful. Bone marrow would have been the next thing to do, but I think that was not done. Was bone marrow done, ma'am?
No, this is actually a small primary care setup. Here,
Yeah, I understand.
arranging bone marrow biopsy was very difficult.
Yes, ma'am, I understand.
I understand that with their situation, I think you have given the best care that was possible. If they have gone to somewhere else, I don't know what might have happened. So I think with their living conditions, you were able to provide the best care. We offer palliative or supportive care with limited resources.
Sunil sir?
Yeah.
Sir, your voice is not audible.
Okay, I was saying that Dr. Jeena and the team were able to provide the best care that was possible considering the situation, the patient and her son situation. So regarding investigations and things like that, we have many questions, but their center is very running with very limited resources, and they cannot do more than that. So every institution or every person has their own limits. So I think they have done or managed the patient well as per the resources. So could we offer palliative or supportive care with limited resources and minimum expenses? So what is your answer, Dr. Jina?
I feel yes, because in this setup where we had very limited resources and we didn't have much money for this patient. It was, we had just given even the son who was not earning anything, and he didn't have any source of income. It was just with the mother's pension amount was he living. So it was very difficult, but we had little funds from people who have donated for palliative care. And with the little funds, we would manage. All these medications, extra medications were all stopped. In fact, except Vovaran towards the end, only diclofenac was the only medication she was on. And even the gloves that we used to autoclave it and use it again and again, because we cannot afford reuse. We cannot afford to buy a new pair of gloves as well. And rest, we would do things like positioning the patient so that bed sores, or maybe we don't have air mattresses and so we couldn't afford to get one, but we would for the future. So what we used to do is fill water in the gloves and then tie it and then use it like a water cushion for all the wounds. This was the limited thing that we used to do for the patients here.
Okay. So I understand that you are unable to provide treatment free of cost for most of the patients because you also need resources. But you have a small fund by which you can help some of the patients. Am I right?
Yes, yes.
Okay. So even for dressing materials, we can make it locally with used dhoti or something like that, and sterilize it. Even in the home setting, we can adapt. So those are something which can be done to reduce the cost of treatment. with limited access to CT scan and high-grade antibiotics, did we do justice to the patient with regards to the management? So I'll ask this question to Dr. Abir. Dr. Abir, are you there? No, I think Abir is not here. So anybody, what do you think?
Hello, Dr. Mahesh here.
Yes, Dr. Mahesh.
I think they are doing wonderful job with the limited resources and limited financial fund, and I my best wishes with them for continuing this palliative care of the patients.
Thank you, Dr. Mahesh. Dr. Zina, you have done your best. That's what we all think with the available resources.
Sunil sir?
Yeah,
Sir, not audible, sir.
with available resources, Dr. Jina and team has done a wonderful job. So I think we should thank them and for making the life of that patient comfortable. And I think the best thing that you have done is the rehabilitation of her son. So you were able to provide a job for him, and maybe that itself might be a stimulation for tackling the addiction behavior. So I think that was the most important part of this patient story. And how do we assess pain in such patients who are bedridden, won't vocalize their concerns? Anybody? How can we assess the pain of the patient who doesn't verbalize?
The visual.
Sorry. Okay, Dr. Dumkumari says visual analog scale, but yeah, but if the patient is if the patient doesn't have the mental capacity, so visual analog scale would not be it will not be the apt one in that situation. Wong-Backers, even Wong-Backers, yeah, if the patient doesn't have the mental capacity, Wong-Backers is also not going to help, because in Wong-Backers scale, we have a series of phases, and at the one end, the patient, the face is smiling, and the other end, the patient is crying. So we have to show it to the patient and ask them which phase is the corresponding phase now. So that also will do good only if the patient has the mental capacity. But if the patient doesn't have the mental capacity and unable to vocalize, then what would be the case?
So by the posture of the patient, the facial expression, there is some pediatric scale is there, no? For pain,
Yeah.
maybe we can apply that.
So Dr. Avanish says subjective signs like heart rate, blood pressure. Okay, and Dr. Avanish, yeah, that's one thing which you can measure, but in chronic pain, that also is not going to help. In acute pain, there will be a more heart rate, but in chronic pain, it's all like vegetative symptoms. So a few things, and what you have to understand is, in many situations, they have many types of scale. So suppose the patient has dementia, then there is a scale. There are many scales, but one scale is advanced pain assessment in advanced dementia scale, PAINAR scale. And American Geriatric Society has come up with a scale which measures the pain by observing the pain behavior. So which includes facial expression. Is the patient having verbalization or vocalization? How is the body movement? Is there any change in the interpersonal relationship? Are they aggressive? Suppose when somebody is giving care, are they resisting it? And are they interacting with anybody? These are something in changes in interpersonal relationship and changes in activity patterns or routines. Like are they refusing food, or are they sleeping? How is the rest pattern changes? So many things. And how is the mental status changing? Are they crying, etc. So these are some behaviors which you can observe, which indicates that the patient is in pain. And in neonates, we know that we can't ask the patient, and we have to observe the patient. So there is a scale called a FLAC, FLACC. That is looking at the face, F for face, how is the face, then leg, how are they keeping the leg, A is activity, is the patient active, and C is cry, how does the patient cries, and next C is for consolability. So usually the children will keep quiet when they are in mother's hand. So are they still crying? So these are some non-verbal pain behaviors that we can observe, and then come to a conclusion that this patient has pain. So there are many scales to assess pain in these patients. Okay. So the next question is, in such situation like this, where the patient and the caregiver are not in a condition to decide anything for the patient, the important pillar of medical ethics, autonomy, is at stake. How can we tackle it? Yes. Anybody?
We can decide upon the best interest of the patient.
Yeah. Yeah. That's what we can do, because patient and the son is unable to execute their autonomy. So in such situation, we can act in the best interest of the patient. So what you have done is, because you have a very limited resource setting, and in that setting, maybe you have a team of doctors who have seen them, and you also offered the comfort care for the patient. So that's what we can do. So we have to act in the best interest of the patient. So anybody else have any more comments?
Dr. Sunil, I have one question that it's not related to this case particular. But
Yeah.
in case of this, when we come across this end of life care and all those things, what do you prefer? Like with your experience, is it better to have a palliative care in each hospital as a separate department, or it is better to have a palliative care as a standalone unit, like in most small towns with a small admission facility, or it is better to have something attached to a hospital as such?
Yeah, I understand your question, and I have worked in a setting where palliative care department is separate. But I also know that doctors, my friends who are working along with other teams as a team member. So both has its advantages and disadvantages. But what I want to tell you is that another thing, if the palliative care principles can be integrated into the practice of each department, and then we can have a specialized palliative care department, then it will be better. Otherwise, the problem is that if the palliative care department is standing alone, then and if you are new to the hospital, the problem is that there will be resistance from among the professionals. So it will take time to make them aware about palliative care and what palliative care can do to the patient and family. But once once the other departments see how palliative care can help the patient, then they will definitely refer the patient. This is my personal experience, because when I was working in the biggest hospital, the palliative care was just established, and we rarely had a few patients from oncology. No other departments usually refer the patients. But in the next 2 years, we created awareness among professionals, and whenever we see somebody, we will make them stop and tell them, talk to them regarding palliative care. And many departments started referring patients, including the neurology, who is supposed to be one of the pain treating department. So even they refer the patient to us for pain management. And the gastro surgery department, who come to us and tell them that, okay, once we were asked to take a class for them. So they told that we are doing surgery, but we don't know what happens to them. You are the people who are tackling the situation after our surgery. So I think this will take time, but the principles of palliative care has to be integrated in the practice of each professional. So, Dr. Abir, I have not given you a straight away answer for your question.
Yeah, no, I got the point. Actually, when we look up all the classes we did, I think each department, in each department, we have certain cases which actually should be better dealt with a palliative care physician rather than anyone else. So probably, as you told, the first thing which we have to start is to inspire our own colleagues to learn about this options, and then so that they can refer, and as you told, we should show them a model of treating and what difference we can make. Then only these things will come into practice. The same was the situation when I started practicing emergency medicine, and nobody know what it was. So and over the years we were able to make the difference. So
yeah, actually, like I wanted to say that another story. 2 minutes. So we had a gastro surgeon. His wife is a nephrologist, and she has had some malignancy, and she was in severe pain. So the gastro surgeon brought her here, and she was under our care. So we had a very good rapport with him, and actually from that department we didn't had much referrals, but when we had another patient here, we needed to take help of a gastro surgeon. So we requested his help. He immediately accepted, and he came. Actually, a person from medical college who is a professor will not come to see a patient in another institute. So he came and actually told us, okay, if the better person to see this patient was somebody else. He meant his wife. He had some urological problem. His wife was a nephrologist. So he extended his help only because he actually understood what is palliative care, because from his personal experience. So once you become experienced, or the one who receives the care, then only you will understand what palliative care can do to the patients and family. So, Dr. Jaina, anything else? So, I think we can wind up the session for today. So, thank you everybody for your active participation. And next Wednesday is the last session of this FCPM batch. So, thank you. We'll see you on next Tuesday. Over to Arun.
Okay, thank you, sir, and thank you, Geneva. And I request to do the feedback now. It's always there. And next week we have our last session on opioid availability. The session will be taken by Rajagopal, sir. Okay, thank you.